Hello, thanks very much for inviting us to present today. I'm going to talk about an evaluation we carried out in North Central London. I'm talking here on behalf of our collaborators and colleagues, embedded researchers within North Central London, and also to say thanks to our lay advisors who've been really helpful in helping us articulate what this project's about. So for those of you who are wondering, what is population health management? So it can seem quite an abstract idea, really, but it's something that it's an emerging approach that's been gaining steam, building up attention, particularly in the NHS. And the kind of technical side of it is it's about bringing together information, bringing together patients' records across lots of different organisations, presenting that information in a usable way in order to change practice. So the image on the right comes from the particular product that we're going to be talking about, which is North Central London's COVID-19 vaccination dashboard. And you can see a number of ways in which they've sort of visually highlight where attention might be focused. So through maps, you can see the colours of particularly very small areas where vaccine uptake was low. You can see the use of bold text and highlighting languages as well. So population health management has this one aim, which is about understanding one's population. And so all this whizzy technical stuff about bringing data together, that might help with the understanding. But the holy grail that we often don't focus on is, well, how do health and care professionals use this information? You know, what do they actually do with it? It isn't a given that practice will change. And so this is really the focus of our evaluation. So how do staff use population health management to inform their decisions and ways of working, and in particular to reduce inequalities? So I'm going to very briefly sum up our methods, which is a mixed methods process evaluation. So that's using some numerical data. So this is about staff usage, that the dashboard automatically collects all the information on and staff. You know, every time staff access these systems, it collects that information, and that's what we used. We also did some interviews with health and care professionals across North Central London. And then we brought these findings together to kind of bring out some additional insights. So moving on to the findings, this is from our quantitative analysis. It's very descriptive, and it just shows you on the y-axis, so going up, you can see what are called events. And these are counts of when people have clicked on the system, they've logged in, they've downloaded anything. And I'm going to just draw your attention to two things. So firstly, that you can see that usage was highest, this graph peaks at February time. And you know, I'm sure every one of us remembers last year and remembers the massive efforts for vaccination uptake. And this was the point where services had this big deadline to have offered vaccination to their 4 first cohorts. So these are the extremely clinically vulnerable social care and NHS staff. The other thing I draw your attention to is that this line in the blue, these were our highest intensity users, and these came from the clinical commissioning group, the kind of management side of the NHS system, rather than our GPs who comprise the greatest numbers of our users. So that's what the numbers told us. The qualitative data actually gave us a slightly different picture. So when we talked to our staff, we picked out 4 different types of user, and we've kind of put them in 4 boxes as to their levels of use, but also their affiliation with this particular system, this particular population health management system. So our first box we've called deployers. And these were people that use this system a lot, but they didn't have much investment into it. So as you can see from this quote, we use it weekly. But when it didn't serve their purposes, they used something else. So they might use data from NHS England. They might use something completely different. In contrast, our architects, these were people that they were often quite senior in the vaccine programme. They'd been integrally involved in developing this particular product. So they'd advised on what information should go in, how it should be presented. And for them, they lived and breathed it. As you can see, it's open every day. So the particular product's called Healthy Intent there. This group called endorsers was one that would be invisible in our quantitative data. We would never have found them. So these were often very senior people in the health and care system. We've called them indirect users. And as you can see from this quote, I don't sometimes look at the data. I will literally just get a verbal update from someone. So these people were actually using these data in a very impactful way without actually looking at it. Our fourth group, I've just put in a different colour because I think that's where we felt that usage was low and could have been higher. So these were often our clinicians, but not always. Sometimes they had lower data literacy, but not always. This wasn't about a lack of understanding. It was that the system didn't really work for them. But then we go on to, well, how did they use this? What did they really think was the impact of it? Can we see changes in practice? We did get some tangible examples of why this system was different for them. It showed them information they didn't get otherwise. So the dashboard showed them small area geography, so it showed them areas that they couldn't otherwise have seen. And it also told them about the language spoken. So often these groups, if you have an ethnicity sample, they're in the kind of white other, and actually their needs are kind of invisible in that. I'm going to go through how it informed practice in a bit more detail, but it allowed them to target things in a way they couldn't do otherwise. And the thing that we weren't expecting to find, but that we did, I think, was that it seemed to facilitate some kind of system working. So this thing called integrated care systems, now integrated care boards, these things were very new in 2021. So they were only formally kind of constituted in July 2021. So these were people in new roles or who hadn't ever worked together. And it seemed like actually looking at the same data was fostering some kind of identity there. So I've put up a number of different examples of how they were able to use information on inequalities to do something different. You might remember the early days of the vaccination programs. We had these massive, large centres, these very one-size-fits-all, a kind of horizontal equity approach. And actually, by being able to highlight where vaccination was low, it gave them the arguments to be able to invest in some vertical equity approaches. And not just that, it also gave them the intelligence as to how to do them. So they translated into Spanish because it was Latin American communities that had lower uptake. They commissioned pop-ups in centres where young people would be. They deployed staff who were reflective of the communities where uptake was low. And they used it, for their really high intensity things, they used it to kind of plan their route for the vaccination buses. So to summarise, what we heard from this example about population health management, so this is just looking at one tool, the COVID vaccination dashboard, but what we learned was that the people use these kind of things in very different ways. We'd gone into it with this expectation that, more usage would equal more impact, but our qualitative data challenged that. We can see that it was allowing them to understand their population, and particularly by giving this idea about where there are targetable inequalities, where you can do something, and to take actions from that understanding. And our sense now is that it enabled them to take a bit more of a vertical equity approach. There are many caveats to this. One of them is that, yes, it didn't work for all groups, that there were this group of questioners, and one of the key lessons that North Central London are working with is on their communication of the system, but there are other problems there too. And context is clearly really important. So one of our interviewees said, this is the most important thing I will ever do. So this is a very singular context, but actually there is some learning that we might be able to draw about where population health management can be useful for other services and for other decisions. So that's the direction of our work at the moment.